In this review, we'll talk about myocardial infarctions. So what is a myocardial infarction? This is when there's a complete blockage of the vessel. So when we talked about ischemia before, we talked about a buildup of plaque, which then limited blood flow. When we talk about a myocardial infarction, there's actually a complete blockage, and blood cannot get through at all, leading to myocardial death. When this happens, there's different zones of infarction, or the muscles affected in different ways. The zone of infarction, this is the part of the injury, or part of the heart that's taken the most significant hit. This tissue is pretty much dead. The zone of the injury, the muscle is still alive, but it's been negatively impacted and probably not going to be able to produce as much force as it did before. The zone of ischemia, the damage done there is typically reversible. It had some ischemia, but after blood flow is restored, it can go back to its normal health. So what's happening? The myocardial cells are damaged because of a lack of oxygenated blood, and the key thing, it leads to death and necrosis of the cardiac tissue. And the long-term effect is contractility problems, which then affects oxygen delivery, which then affects quality of life. How is the MI diagnosed? Three main things: chest pain, EKG, and the cardiac enzymes. The symptoms, patient will typically report of pressure, squeezing, lightheadedness. They'll be sweaty, they'll be pale, nausea. Sudden death is actually a symptom of an MI, and obviously the most severe symptom of an MI. On the EKG, remember when we talked about an ischemia, what did we see with ischemia? Well, we saw an ST segment depression. So the depression is what indicated ischemia. When we have a myocardial infarction, though, what we see is ST segment elevation, and you see the example of the ST segment elevations there taking place. Also a Q wave. You see a widening of this Q wave, I should say. Let me take a step back with you there. The Q wave right in here, you see that area widen. That can be another indication of a myocardial infarction. When when you go through a heart attack, there's damage done to the cardiac cells, which causes the release of enzymes, and we see those enzymes peak and come down at different times, and that can give some insight into how long ago the heart attack happened, how severe it was, and if damage is still being done. During the acute phases of MI, it's about controlling the symptoms and getting the heart back to its proper function. What they say is that MONA meets everyone at the door. The patient gets morphine, oxygen, nitroglycerin, and aspirin. This will decrease the workload on the heart and help decrease the damage. And then what they have is they go through a series of workup, tests, and measures to truly diagnose the myocardial infarction. Pharmacological management, the fibrinolytics, which can be used to break up or dissolve the clot. Also antiplatelet medications. It's typical that the person may be having some arrhythmias during a myocardial infarction, so medication to control that. The more typical treatment is going to be a PCI or a PTCA. Percutaneous coronary intervention is the term used most now, or a CABG, or coronary artery bypass graft. So with the PCI, what happens is a catheter, we have a vessel that's blocked. What happens is a balloon or a probe is going to go up, and there could be clots that are forming on the side of the wall like this, even blocking it. The balloon is actually blown up, and it pushes the clots out of the way, so it opens up the vessel. And then what happens is that balloon is taken out, and then a stent is put in. So you come in here, and there's an actual stent that gets put into the heart, and I'm not a very good drawer of that. And I think the next slide you'll see an actual picture one that helps hold the vessel open, to keep that vessel open and allow blood flow to be restored to the heart. And there you go. You see an example of coming up the femoral artery up in the aorta into the heart. You see it going into there, and then that balloon is used to open up the blockage. And then that wire mesh, as you see here, much better drawing, is used to give it some infrastructure and support to keep the vessel open. Now we'll talk about a CABG. With a CABG, a coronary artery bypass graft, this is a much more involved procedure. The sternum is actually opened up, so you see the example here of the sternum being cut open because they're going to expose the heart. The heart is exposed. The heart is actually stopped. In many cases, the patient's put on a heart-lung bypass machine. A graft is taken from either the leg, so they take a vein from the leg, and they're using that to bypass the blockage. So in this picture here, you see there's a blockage there, and then the vein is used to connect in the aorta, comes down around the blockage to reestablish blood flow to the heart. The radial artery can also be used too, and you see another example there, or the internal mammary artery can be used. This is just talking about the bypass machine where they actually stop the heart to allow surgery to be done on it. There is something called a minimally invasive bypass where they come in and, this you see in this picture here, they're making a few smaller cuts, opening up the ribs, going in with a laparoscopic type procedure with cameras, and they can do the surgery on a smaller part of the heart without the complications, ideally, of the sternotomy. Less pain, faster recover. There are complications that happen post-sternotomy, and this is something as physical therapists we may see when our patients come to rehab. There can be instability, opening it up, dehiscing, those sort of things that can take place. And you see the rate varies, but when did most of these complications happen? Well, the research shows 14 to 21 days after the CABG. So where are these people at? Typically they're in rehab. They're in cardiac rehab, physical therapy. That's when these issues pop up, and that's why it's important for us to know about them. These are risk factors associated with sternal complication. You see you could break them up if you wanted to. This top part of the list, these are things that the patient controlled, the risk factors maybe, and the lower are things that how the surgery went or what was going on for the individual, and that's probably not exactly right. We should probably move this up to that list if we want to truly reorder that. So some of these things, the take-home point is some of these things are based on the individual's genetics, their risk factors, their past medical history. Some of it's based on the surgery itself. As physical therapists, we have to be aware of lifting precautions or sternal precautions. After sternotomy, typically you're not supposed to lift heavy objects or even light objects, I guess, for about 6 to 8 weeks. You want to avoid unilateral, and that's the key, unilateral shoulder elevation, abduction, flexion. And then you want to avoid pushing up from the chair. That's probably the big one, especially for physical therapy. You're getting somebody up out of bed, they want to push with their hands. That's going to put a lot of stress on the sternum. That has to be avoided. This is one of those things, though, you'll see different doctors do different things for this. So knowing what the referring physician wants, being aware of the signs and symptoms, education what the patient can't do, but don't forget about what they can do. You see patients think they can't move their neck. You have patients who think they can't take their arms up above their head ever. You need to tell them what they can do so they don't avoid too much activity. Long-term management, in the previous lecture about CAD, we talked about risk factor management, importance of exercise. These patients are also eligible for cardiac rehab services and should be encouraged to attend that. So that gives you a summary of recovery and treatment of a myocardial infarction.